Dr. Williams, I was hoping you could talk with us a little bit about some of the different MAT modalities.
For treating opioid use disorders.
Mm-hmm.
Sure. So MAT, medication-assisted treatment, sometimes people say medication-assisted therapy, for the treatment of opioid use disorders refers to 3 different medications. Methadone, which has been around since the 60s. President Nixon funded methadone heavily when Vietnam War veterans were returning to the United States. Buprenorphine, which since 2002 has been FDA approved for the treatment of opioid use disorders, and also naltrexone and its extended release formulation, which is a monthly injection of naltrexone called Vivitrol, which is also FDA approved for the prevention of relapse in opioid use disorders. So MAT really stands for those 3 medications: methadone, buprenorphine products, and naltrexone, and the extended release monthly injection. They differ in important ways, and there are pros and cons to each modality. There are advantages to methadone for some patients, there are advantages to buprenorphine for some, and there are certainly advantages to extended release naltrexone for some patients as well. But there are also drawbacks to each of these modalities, and it's not just differences in side effects or differences in induction mechanisms for getting people successfully onto the treatments. There's also some nuance in terms of how people respond to them. So, for instance, methadone in the United States is largely provided through heavily regulated clinics, federally regulated and state-regulated clinics. So there's a lot of services built into these programs, but the patients have to go every single day, 6 days a week, for months, if not years. If patients go and they're really successful in treatment in terms of not having any opioids or other drugs of abuse in their urine samples, they attend every single day without fail, then they can start to earn what are called take-homes in the field, where they only have to go every other day, maybe even once or twice a week over time. But even patients who've been in methadone programs for years, very successfully, if they miss a couple days due to a family crisis or some other disruption in their life, often they get kicked back to 6 days of attendance on a weekly basis. So imagine having a job, trying to raise kids, you have to be somewhere every single morning at 8 a.m. That really cuts in your ability to have a functioning life. So methadone is a great option for people who need that structure, and in particular early on in treatment, that amount of regulation and structure can actually be therapeutic, but obviously there are major drawbacks to that as well.
So Dr. Williams, I've heard a lot about the dangers of methadone, that it's a great risk for folks overdosing on it, and there's been a lot of talk about restricting its use, and you're talking about it as a evidence-based MAT medication. I was wondering if you could kind of explain the differences there.
Very, very important point to clarify. I'm glad you asked. So if you look at overdose trends in the United States over the last few decades, disproportionately, a lot of overdoses are with long-acting or extended-release opioids. And methadone's a long-acting opioid. It works it stays in your system for 24 to 36 hours. But the pain control, the pain effect, the analgesia only lasts for about 6 to 8 hours. So unfortunately, a lot of prescribers, a lot of physicians give methadone prescriptions in pill form to patients to treat pain. And they're told to take it once a day or twice a day. But the reality is that the pain control only lasts for 6 or 8 hours. So inevitably, patients take it every 6 to 8 hours because they start to experience intensifying pain if they don't keep taking it. But the blood levels continue to climb for 24 to 36 hours. And as a result, people might take a couple extra doses of methadone on day 40, and on day 41 they actually get toxic blood levels. But they have no idea that this is happening, of course, and they overdose. So if you look at the overdose deaths that are associated with methadone, almost all of them are with the pill form of methadone that's prescribed from emergency rooms in the outpatient setting for the treatment of pain. It's not with liquid methadone, which is directly dispensed in methadone treatment programs. Remember, most people who go to methadone treatment programs are going every single morning, six days a week. They're directly observed taking their methadone in the clinic. If you look at the community, though, the patients who overdose on methadone, they're largely overdosing on pills, either their own or pills that have been shared between friends and family, which is one of the most dangerous things that people can do.
Great, thank you.